All right, so our last section here, dementia and Alzheimer's disease. Dementia is a progressive intellectual decline that eventually leads to deterioration of occupational, social, and interpersonal functions. It results from death of nerve cells and loss of communication among the cells. Alzheimer's results in brain lesions characterized by amyloid plaques, abnormal clumps of beta amyloid protein, and degenerating neurons and other cells, contributing to the destruction of neurons and atrophy of the cerebral cortex. So major risk factors are, of course, age, but there's also genetic or family history components. But risk factors also may include things like diabetes, Down syndrome, mental illness, hypoxia, and anoxia, and then brain tumors or trauma, toxins, environmental toxins, and medications. So there is a higher rate of gingival disease overall, gingival disease and caries with individuals that have dementia and Alzheimer's, and this of course is because there's quite an interruption in their ability to self-care and perform activities of daily living and just caring for themselves. There can be gingival enlargement if they have seizures and they're on certain medications. Xerostomia is also very prevalent due to the medications that they're on. These individuals can, as they deteriorate and in the stages of their dementia, Alzheimer's deteriorates, they may become more uncooperative and combative. They could be frightened and very upset by somebody trying to get into their mouth and clean. They don't understand what's happening. Treatment should be in a calm, quiet, clutter-free environment with the caregiver present, usually is kind of calming and reassuring to the patient. And then depending on what stage they're at, if there's just some beginning stages where there's confusion and forgetfulness, but they still can maintain some of their own care, then just giving slow, simple instructions to the patient and then also educating the caregiver at the same time. And having patience and repeating yourself is oftentimes very necessary. So patients forget to brush, they forget how to brush, they may not want to brush or may resist a caregiver brushing their teeth. If an individual is in a nursing home, long-term care facility, or even just at home and their significant other is their caregiver, if they start to lose their appetite, that may be a sign of mouth pain or an ill-fitting denture if they show signs that they're not interested in eating. And another interesting tip that I learned from a hygienist who speaks on this topic a lot is she said that when you have patients in your practice that are getting older and you suspect some kind of cognitive decline or early dementia or early Alzheimer's, and if they have a denture, you hand them their denture and ask them to put it in their mouth. And if they put it in backwards or upside down, or seem confused at first of how to put the denture back in their mouth, that is, just a total giveaway that something is happening cognitively. And so that's almost like kind of a little test that you can do with your older patients that you may suspect are starting to show signs of dementia or Alzheimer's. So one of the resources that I looked at said to use the watch me technique, hold a toothbrush and show the individual how to brush their teeth, not just to tell them to brush their teeth. Offering both the patient and the caregiver home care items and demonstrating proper oral care techniques to both is an excellent way to educate and motivate the patient and the caregiver and to encourage compliance. So, and I think we touched on some more of those topics too when we did the elderly persons, so that was kind of just sort of a brief recap. But so now cerebral accident or stroke, CVA, it's an interruption of oxygenated blood to the brain. It can be either ischemic or hemorrhagic. So ischemic would be like a blockage, maybe a blood clot. Or hemorrhagic would be like a ruptured vessel and a brain bleed. It's the fourth most common cause of death in the U.S. and a major cause of long-term disability. Common risk factors would be high blood pressure, tobacco use, cardiac disease, and diabetes. A transient ischemic attack, or a TIA, is a transient focal. We saw that term focal, so it happens in just a small portion of the brain, like a localized portion of the brain. So a transient focal neurologic deficit that persists for less than 24 hours and is followed by complete clinical recovery. So there's individuals who have TIAs, sometimes they have many of them and for a long period of time, and they show no clinical symptoms. Most TIAs do not last longer than 10 to 20 minutes, and generally the body dissolves the blockage using its own anticoagulants in the blood, so the blockage is not in place long enough to cause permanent damage to the brain. Here is information from the textbook that I thought was interesting. If damage happens on the right side of the brain, then the left side of the body is affected and vice versa. And so these are if the right side of the brain is damaged, there can be paralysis on the left side, spatial and perceptual deficits, impaired thought process, quick impulsive behavior, patient cannot use a mirror, difficulty performing tasks such as toothbrushing, memory deficit, neglect of the left side. And then if there's left side brain damage, paralysis to the right side, language and speech, decreased auditory memory, cannot remember long instructions, slow, cautious, disorganized behavior, memory deficit, and anxiety. So I just thought that was interesting to see how the different sides affect the symptoms, or the post-stroke symptoms. And then here, symptoms depend on the side of the brain affected. So there's motor impairment, most common deficit, and that it shows itself as cranial nerve functions to the muscles of the head and neck. Reflexes, gait, balance, coordination are all affected. Often there's apraxia, the inability to perform purposeful movement. Then there's sensory deficits, which include impairments range from loss of primary senses such as vision. There could be pain, temperature, touch, to more complex losses such as loss of perception. And that could be a problem, to lose the sense of pain if there's like a toothache or a cavity, but they don't feel the pain from it if it gets big, so that could be an issue. Language and cognition, there's often dysphagia also that is involved there, with the difficulty of swallowing manifested by disturbances in comprehension, repetition, naming, fluency, reading and writing. Strokes can cause deficits in memories, calculation, abilities, attention, and orientation. And the language obviously is the speaking, probably affecting the tongue and therefore the dysphagia as well. Depression, most common affected disturbance after stroke. Symptoms of depression include lack of interest, energy loss, insomnia, and appetite loss. Stroke patients also may display emotional instability. So treatment is reducing the risk factors, anticoagulant treatment medication, antihypertension medication, low-dose aspirin, occupational and physical therapy. The specific oral findings varies depending on the part of the brain affected by the cerebrovascular accident. So motor function impairment, dry mouth, biofilm accumulation. Biofilm diseases is common because of the plaque accumulation and lack of oral hygiene. Periodontal disease associated with risks of stroke and heart disease. So we know that if they've had a stroke or if they have heart condition, we know they're there is a correlation to periodontal disease, so they could be struggling with periodontal disease already, and now they have a stroke and an inability to maybe care for themselves as well as they once did, so it kind of compounds the problem. So if you have a patient that has had a stroke, 6 months for no elective dental care post-stroke, so they have to have, if they've had a stroke within 6 months, you can't see them. Follow-up medical history questions: when did the stroke occur, how to manage pain and anxiety, best way to minimize fatigue and optimize energy, monitor their blood pressure carefully. Infections can affect the clotting factor and could trigger another stroke, so it's important that they have some oral hygiene care, especially in those 6 months that they're not seeing the dentist, so that sometimes it's good to counsel with the caregiver, the spouse, make sure that they're performing oral hygiene, or talk with the physician for sure to make sure that the physician brings up the importance of the oral hygiene. When they do come to see you, if there's excessive bleeding because of the anticoagulant medication, then a physician should be consulted. And then also the physician needs to be consulted as to whether or not the patient needs a prophylactic pre-med before a cleaning. Minimize the use of local anesthetics with vasoconstrictors, so the lowest dose necessary, or a 3% mepivacaine. And immediately post-stroke phase, the caregiver is to maintain the oral hygiene, like we said. Specially adapted oral hygiene tools may be needed. Advice for the caregiver and the family of how to help with the oral hygiene of the individual. Writing out instructions for them is very helpful. As the motor skills, oops, we got to fix that typo. As the motor skills improve, aids may be still needed to various degrees, so they may need a modified toothbrush or an electric toothbrush, or their caregiver may still need to help them if their dexterity and coordination is not good enough to perform good oral care. And then fluoride therapy, saliva substitute, xylitol, all to address any kind of high caries risk or dry mouth. And I just wanted to, there was the last paragraph in this chapter was really good. And so it says, individuals living with disabilities have a higher incidence of oral disease than the general population. Dental hygienists can integrate their knowledge of patients with special needs to make a difference in a population that may not have access to care. Working in public health and partnering with organizations that serve people with disabilities, dental hygienists can provide education to individuals and their caregivers on proper oral self-care, good nutrition, and the importance of maintaining regular preventive care visits. Furthermore, dental hygienists, in collaboration with other healthcare professionals, can provide referrals, if necessary, to specialty dental or medical providers. And lastly, dental hygienists can work with nurses and other allied health staff to improve oral health outcomes and and how to follow best practices. So we make a huge difference in the lives of individuals who have limited access, who can't get into the office to see, or those who can get into the office. But the biggest takeaway is that dental hygienists have to reach out to these other communities. We have to reach out to the families. We have to reach out to the other healthcare providers and find out how we can insert ourselves into the lives of individuals that have special needs, so that we can be there to educate the family members and encourage good oral health care to just overall improve their lives. So I just wanted to end with that little bit, and that's it. And that's a cute little puppy.